Well, good morning, everyone, and welcome to CVI 2023, Austin edition, heat edition. And sorry for the hot weather. Jamal looks really cool and comfortable. Perfect. So we have a new format and venue this year, and I hope you enjoy it. We want to make this as interactive as possible. So we have a nice catwalk up here at the front, and the first person for the catwalk is Dr. Boling. So please enjoy and let us know how much you like this, but we want to make this as interactive as possible. And Dr. Bolling will kick it off with our keynote speaker on things you should know from surgeons for TR.
Okay, so thanks very much. Don't start that clock yet because I don't know what I'm doing. And I'd like to thank Paul for inviting me down here. As a surgeon, when you're given a title like this, that either means you are dying, which I'm not, or you're retiring, which I'm not, or you're old. Okay. So I was assigned lessons from surgery, and I'll go ahead and start. Now, am I going to be able to look at my own slides somewhere because I don't see them anywhere? There we go. Okay, go back. Okay, so lessons from surgery, tricuspid, transcatheter tricuspid. And the answer is, it's just math. That's really what it is. I'm a math boy in college. Paul knows that, so a lot of my life is math. So first we'll go through a lesson. Is TR important? Yes, TR patients feel terrible, and it makes them die. Whether you have severe or moderate TR, you die. And again, you have to show the Topilsky study. Severe and moderate TR have a mortality ding. It's bad. You're going to die if you have TR. If I leave TR after surgery, that's bad. The more TR I leave, the more bad it is. Moderate TR will kill you. Severe TR will kill you. Even after a percutaneous procedure, TR is bad. I know that's unbelievable. But moderate TR after a clip is bad and leads to a worse outcome. So let me summarize for you. TR is bad. Now, that used to be a lesson that we didn't know. We didn't pay attention to it, but clearly TR is bad. But what about the lessons to fix it with a catheter? So severe TR, what should we do? Well, let's think about it. Let's take a step back and say, how does the tricuspid actually work? The tricuspid is functionally a bileaflet valve. It coapts exactly the same as the mitral. Now, the echo people in this room are having a cow right now because they're saying, well, sometimes it's 3 leaflets, sometimes it's 4 leaflets, sometimes it's 7 leaflets. It's a bileaflet valve. It works like a Roman arch. That's exactly what it is. These two surfaces oppose each other and make a Roman arch. This is how every AV valve works. It's a Roman arch. It's just math. And what happens is we have to lay a keystone in that. If you think of it, that's a brilliant design. If I give you a bottle of pop and have you shake it, the cap eventually will blow off. But a Roman arch, as the pressure goes up, what happens to that Roman arch is it sticks together more. And it's a beautiful design, gives us a blood pressure of 20, 40, 60, 80, 2,000, and that AV valve, including the tricuspid, is competent, but the keystone has to be intact. Everybody knows that's true because we've all seen Roman ruins. No ceiling, no floor, no walls, but what's still there? That Roman arch in the entryway. It is a very stable design. But it depends on the width. The AB width between the legs of the Roman arch have to be intact. And if you don't have it, you have tricuspid regurgitation. And in fact, tricuspid annular dilatation, which exists in about 75% of the patients who have MR, they've lost their coaptation reserve. As you see, the tricuspid valve changes from an ovoid to a circle. So if somebody has MR, they're already losing their reserve of coaptation. And it's really just math. If the tricuspid annular diameter is 30 or less, you do not have TR. If it's 40 or more, everyone has TR. That's a very good population study. If everybody goes like this, that is the size of your tricuspid valve, about 2.8 centimeters across, and it's very tightly held in the population. So the math of an annuloplasty should work. If I somehow am able to shorten up that A to B or anterior to septal diameter, it will work. I will change A to B and reestablish normal coaptation. And in fact, it does work. If you look at this paper from Dreyfus, 300 patients he put an annuloplasty on, sort of randomized, you can see that tricuspid annuloplasty works great. You can see 2 years later, the patients who had only a mitral, 50% of them progressed their TR. If you put a ring on it, then only 2% of them progressed their TR. Annuloplasty works incredibly well. It normalizes that A to B distance. It enhances coaptation. It makes your Roman arch better. And in fact, this is Jim Ganby's first paper where he said, I'm going to undersize these rings. He's really re-normalizing the rings because he put a 28 ring on everybody, or 26. And everybody did great because he reestablished that Roman arch. This is our paper, 262. This is Dave Adams' paper, 645 patients, exactly the same way. That's 1,000 patients I just showed you that annuloplasty works really well. The average number of tricuspid cases per surgeon per year in the United States is 0.8, less than 1. So this is centuries of tricuspid work for the average person. Annuloplasty works really well. Okay, but we don't believe that. So we had to have a randomized prospective trial. We did, and published in the New England Journal. My name is on there. Oh, no. And survival is exactly the same. Remember, TR people die slowly. But our primary endpoint for TR was met, and it was mostly because we stopped progression of TR. And in fact, if you put a ring on it mathematically, it was greater than 1,000% less TR progression if you had a ring on, as opposed to not a ring. 1,000%. So, and we know that. As surgeons, I have made that patient pay the ultimate price. I have whacked them open. I could do anything I want. I can replace the valve. I can put a ring on it. I can pour cement into the tricuspid. And 95% of the time or more, we put an annuloplasty on the patient and it works. Why? Because we inherently know that enhancing coaptation works really well. So let's review. TR is bad, annular reduction, good. So the perfect catheter device would give us annular reduction, just like we do at surgery. It should be safe, easy, fast, all those things. Future options left open, compatible with pacer leads if you have them already. No pacer needed afterwards, simple imaging, no anticoagulation, et cetera, et cetera. So why not just put a catheter annuloplasty on there? There are catheter annuloplasties that we've tried out there, Cardioband, Millipede, and so on like that. Ooh, they are difficult. They are complicated. They're long procedure times. It's very hard to recreate what I do under direct vision exactly. What about not doing it exactly? Let's do it a different way. Must every catheter device recapitulate surgery? Absolutely not. Does a stent look like what I do at coronary bypass? Absolutely not. Does this work? Absolutely not. They left a 10 square centimeter orifice. That's the size of my head. So, of course, they had massive TR and it didn't work. So, yeah, this is what they left. So maybe they could just plug that A to B distance. Okay, that was easy, but it didn't work. Must every catheter device recapitulate surgery? No. But it has to have the same biologic effect. Come on, guys. What about clipping it, which does not change the A-B distance? Everybody knows this. This is the TriIlluminate trial. Not perfect results. 50% of the patients had moderate or severe at the end of the day. We know that that left them with a mortality ding. Now, this is where my math senses go completely wild. This was a waterfall cascade of wins. So, you know, if you don't win on the first thing, you don't win on the second thing, you win on the third thing, you know. So what we won on in that was KCCQ, and it was all driven by about 25% of the patients who had a really good result and reduction in TR. So this study tells me, okay, it's a positive trial, and it also tells me if you get rid of TR, the patients feel better. Duh, I think we already knew that. So if you review this trial, there's no mortality improvement, there's no heart failure improvement, there's no 6-minute walk test change, and KCCQ only have 2 grade less TR. The problem with this analysis is the Finkelstein-Schofield cascade went opposite ways. Make my math senses perk up. But it is a positive TR trial, meaning if you get rid of TR, the patients will feel better. We know this from the mitral literature that if you don't reduce A to B distance, you're going to fail. The biggest predictor of failure for mitrals is no annuloplasty, leaving a dilated annulus. This is in the Alfier. If you don't leave an annulus, an annuloplasty, you will fail. This is the MitraClip study. Lack of annuloplasty led to failure. This is the COAP trial, which I was in. The bigger the annulus was when we left it, the worse the patients do. It's just math. It's the A-B distance. But wait, Steve. The tricuspid valve is low pressure. The tricuspid valve is forgiving. A little TR is okay. And I don't want to say, did you have math in college at all? Really? honestly. Laplace's law doesn't rely on the pressure in the chamber. It's the wall pressure and the radius, so that as you stretch it, doesn't matter what the pressure is inside, it's going to start to leak. And in fact, if you calculate the A to B, moving from normal 2.8 to 4, which is our trigger to do it, if you calculate it, it's a 204% increase in annular distension, whether you have TR or not. Of course, Laplace's law doesn't count whether you have TR or not. You have 200% more stretch force on there. So of course, if you put a clip on there and leave it dilated, it's going to be under a lot of distension force and keep going. Well, okay, what about complete replacement with a catheter? What should we do then? Well, we can't do the annular thing, the annular math thing, Steve, so let's just replace it. That is really a bad attitude, I think. We would never replace a tricuspid valve. Less than 500 replacements of tricuspid valves in the United States per year. That's it. All the rest are rings, because we know it works. The problem with TTVR is they're upside-down TAVRs. They really are. Everybody thought up a new one and say, hey, let's make an upside-down TAVR. Let's have it do with radial force. Well, you can force that tricuspid annulus super big. They're all mitral rejects, if you think of it. They all were like, hey, they didn't really work on the mitral side. What's that other side where the blue blood is? Let's try that one. And they're all way too big. And so we're in both the Intrepid and Evoque trial, and it has problems. There's a high screen fail rate because the annulus is too small or it's too big. There is procedure mortality. There is pacemakers because you squish on the AV node. And the biggest problem is this RV non-recovery phenomenon, and that's because we're putting something the size of a Diet Coke can in your RV. I want you to do this right now. Everybody take their hand and squeeze as hard as you can. Really, squeeze as hard. Okay, now stick your first 2 fingers out and pin those, and now squeeze the bottom of it. Not as much force. That's what happens when we jack open the tricuspid annulus and try to make the RV work. Doesn't work. Part of the problem is it's too late. They're already cooked. By the time we do surgery on somebody with severe or massive or tsunamic or torrential or whatever our score is now, it's too late. They don't do any better. The horses are out of the barn. We need to do it earlier. And it's really the parable of the parachute. If I take patients and throw them out of a plane, half with parachutes, half without parachutes, the guys with parachutes do pretty well, right? Now I'm going to do it again. I'm going to throw them out, half with parachutes, half without parachutes, but the one group, I strap it to their leg and say, you can't pull it until 5 feet above the ground. All of the patients die, and I agree, like, ooh, parachutes don't work at all. No, that's not the thing. It's just that good therapy applied too late doesn't work. So the market is huge out there, so everyone's interested, and we can do better in this space. There's no doubt about it. So I always end every surgical talk with this slide. Put a ring on it, because that's what we should do in surgery, because we're right there. However, this is a catheter talk, and what we really need to aim at a catheter talk is tricuspid annular reduction. We need to enhance tricuspid coaptation. We need to make a better Roman arch. So I'm going to end it with a different slide. That's what we should do, and this was what Beyonce says. We don't have to put a ring on there, but we have to put something on there that does it. So she says, put something on it early to reduce annular diameter because it's just math. That is not quite as catchy as put a ring on it. Thanks very much.
So maybe I'll open that up to Hursh and Richard and see what your comments are.
So, we're trying to make this more interactive, as Paul told me. So, what I would say is, first, I know there's knocks on the Triluminate trial. I think most of us, I think everyone on the panel here is on the Triluminate trial for the mortality benefit. And if you look, the steering committee decided on a mortality benefit compared to older trials. So, I don't think we were going to match that. I don't think it was going to be predicted based on newer data. But there is something to be said about feeling better. So I would open that up to everyone right now. Like, do you think when it gets approved that we're going to try to make people feel better in non-surgical candidates? Richard? Paul? I mean, that's, we talk about this in interventional cardiology all the time. It's like, are we trying to make people live longer or feel better as physicians? And that's, with non-surgical tricuspid regurgitation patients, what are we trying to do?
Maybe I'll throw that out to the audience and get a raise of hand. So how many people in the audience, if it was approved tomorrow and you had severe tricuspid regurgitation and you weren't a surgical candidate, how many of you would want a TriClip?
So I think we need to get over the concept that it's safe, that catheter therapies are safe. Just, we'll give you that. It's safe, way safer than surgery and so like that. So, but we can do better. Just the concept of making people feel better because they're non-surgical candidates. Okay, would that happen 25% of the time in this trial on a subjective, not objective thing that the patients knew they were in the trial and it wasn't blinded. So, you know, if surgeons tried to do that, we would get nailed on it badly. So I had to say, But I think we can do better. I think we can do better. And I think we all have to put our thinking caps on that this is not the ultimate way. The tricuspid is not the mitral valve. And we took this mitral clip, which is designed for the mitral, and imaged very nicely with a TE. And we said, oh, we'll put it over on this side. The mitral, of course, pressure cycles from 0 to 120 with each beat. And the normal tricuspid, 0 to 22 or something like that. So the thickness of the valves is different, the size of the annulus, the thickness of the annulus, it's a different valve. So we said, oh, we can just clip it. And then, of course, there's an imaging. It's a mile away from the TE. So I think we can do better. And probably the TriClip will be approved, but I think we can do much better.
So I love the opportunity to correct Dr. Boling just a tiny bit. So the
Impossible, Paul.
Impossible. I love it. So he's right, and he says a 25% difference between device and control. That is correct between the two arms, but you have to look at the cutoffs that were used. So remember, in Triluminate, for the primary endpoint, it was a KCCQ change of 15 points. And that was a very high bar that was set to meet the FDA requirements for the composite endpoint. It was 49 versus 25, so a 25% difference between the two arms. But if you look at the cutoffs of 5, 10, or 15 points, which is, you know, a lot of people actually think a 5-point difference is a meaningful change in quality of life, that was met in 81% of the device patients. So it depends on your cutoffs of how you want to look at it. But, you know, you can interpret it one way or the other. But the bottom line is I think it's quality of life. I want to ask Steve, so, you know, this annular reduction, this math part, what do you think of the future of TTVR? Can you describe, because we never send patients to surgery to make things bigger. Right. And your argument here is that, you know, you're really not shrinking things. I mean, tell us about where do you think the niche of TTVR is if we've already agreed upon tricuspid repair?
Yeah, I think that's a good question. If I took a patient to the surgery, I would never put a 54 valve in. Never. I mean, that's just way too big. I would be worried about jacking the RV out. But of course, we put a 54 or whatever size all these things come in are just gymongous. And of course, that's a good example of holding your hand like this or trying to squeeze it just with the bottom of your RV. You hurt these people's RVs. Part of the problem is we're doing these patients way too late in their course of the events, I think. So it may be preordained that they don't do well. However, every time we do surgery, we bring the annulus in, not push it out, we bring it in. So I think we have to think harder about, there are some patients that I think will need a replacement. Patients with pacemaker, lead, impingement, and so on like that. But I think we have to think, as a society, we have to think smarter about how to get a replacement valve in there. And I know there's a million companies out there working on things.
So would you agree that TTVR is most likely going to be somebody who cannot be repaired, transcatheter, cannot have surgery?
I think that the tricuspid valve does not care how we get the therapy there, whether we do it open or catheter or transcranial, transrectal, it doesn't matter. The biology of the tricuspid valve will be exactly the same. And 95% of the time, we get a successful repair in there, you know, by enhancing coaptation. So I think the rules for the tricuspid valve should be the same. And I would say that replacement would occur about 5% or 10% of the time.
Transrectal would be ingenious.
We tried that. There's a really high infection rate.
Paul, do you want to talk about, you know, we harp on this mortality benefit, but you want to talk about how if we're treating left-sided disease so well in the Triluminate trial, do you think that had an effect on our mortality?
Well, it does, and many of you have heard me say these numbers before, is that when you look at Triluminate, management of the left-sided disease was mandatory. It had to be done with GDMT, and it had to be documented with a right heart cath, and the wedge pressure could not be more than 20. So when you look at the old data where TR was really bad, it was in the context of biventricular failure with decompensated, unmanaged left-sided valve disease. When we look at patients now with TR with managed left-sided valve disease, the one-year mortality is only 7 to 14%. And in Triluminate, even though 71% of the patients had massive or torrential TR, in the control arm for the entire year, the one-year cardiovascular death rate was 4.7%. So the patients weren't dying as quickly as we thought they would, and it's quite surprising. So I don't think it's going to be about mortality. I think it's going to be about symptoms, and we'll see what the long-term shows. It's hard to believe that severe symptomatic valve disease of any sort would not impact somebody's life in the long term at some point. I just don't think it's going to be a year. It may be 2, 3, or 5 years, but we'll see.
Paul, I think that looking at 1 year mortality for a tricuspid trial is probably incorrect and too short. And it should be, like you say, 2 year, 5 year, and something like that. Yeah. However, as a surrogate of that, there's no study out there that doesn't say if you leave a patient with moderate or severe TR that they won't have a mortality ding. They will have a mortality ding.
At some point, yeah. Great. All right.
So I'll introduce our next speaker. Nadira Hamid is going to talk about her ultimate tricuspid case, concise case evaluation for transcatheter repair.
Thank you very much. I think it's hard to beat after Dr. Steve Bolling. Love that talk. And I think, in terms of my most challenging tricuspid case, you can put my slides up, please. And by the way, I love this catwalk. These are my disclosures. And to me, being part of the Triluminate trial, I thought of this exactly 1 year ago. What is the big 5 for the TR success? And I was sitting in my apartment in New York before my transition to Minneapolis. My big 5 when I was in Safari, to think about for TR therapy. And I thought of this acronym GALEO, which is, I think, really helpful for me. And I'm just sharing with you, thinking about gaps, seeing how small or large gaps during your TE screening, thinking about the anatomy. And I do believe there are multiple leaflets. To Dr. Steve Bolling, you have multiple 3, 4, 5 leaflets, looking at the leaflet length, the mobility, and the different coaptation planes, looking at leads, the location, the impingement, the interaction, imaging from a transesophageal window, is it horizontal heart, is there shadowing from a prosthesis, and looking at other pathologies as well in terms of the right ventricle, the pulmonary vasculature, and also the left-sided heart disease, as the other speakers and panelists was talking about. But another cohort of patients that we are seeing a lot in our clinics, as you all know, that patients with leads, they come with severe, massive, and torrential TR, and it's a huge problem in our community nowadays. And so this is a case you can see on the left-hand side, a patient of mine, a couple of weeks that we imaged. You can see the lead very taut, really embedded into the subvalvular apparatus. You can see it's central, there's no leaflet impingement, really causing severe TR. The question then for this patient is, are there treatable gaps in terms of the TR therapy? And so this is a case example, thanks to Paul and Richard sharing me with this case. You can see on the left-hand side, horizontal heart, torrential TR. Looking at the transgastric view on the right-hand side, top right-hand side, you can see the lead. This is multiple leaflets. There's 2 posterior leaflets, type 3B morphology. The lead is placed in the posteroseptal region. You can see on colored Doppler that anterior to the lead, you can actually place a clip, and that's what Paul did. You can see he placing a XTW in the anteroseptal region, reducing that significant TR. So the question you always have to think when you image patients with lead, are there treatable gaps? And so this is a case, a 77-year-old female, a patient of ours as well. You can see on the left-hand side, and during the screening TE, that lead is really kind of flexible, very mobile. RV inflow-outflow view, you can see torrential TR or severe massive TR really around that lead. Looking at your transgastric, that is the key view. The lead you can see is mobile in your AP plane. That is a sign that you can actually move the lead, and that's what we did. So using the left femoral access, 8.5 French agilis, so what did Paul do? You can see moving that lead towards the postural septal. These are fluoro images, and you can see on the right-hand side with that and correspondingly simultaneously TE imaging, putting that lead in the anteroseptal region. You can see the agilis catheter moving that lead into the postural septal region. So here's the corresponding TE image. As he maneuvered the lead towards the postural septal, you can see on the right-hand side, the yellow image, the lead moving towards the postural septal, giving it enough slack and room to place the XTW in the anteroseptal region. And so this is the first XTW, placement of the lead, capturing the septal leaflet on the right-hand side, and then maneuvering as well, putting a second XTW clip next to the first clip. You can see on the corresponding right-hand side that reduction in TR from the patient. And these are the final images of the patient. You can see with ICE catheter on the left-hand side, the middle image, a transesophageal image. You can see significant TR reduction after placement of the 2 XTW. With the fluoroscopy image, you can see stability of the 2 XTW. And then removing the agilis catheter with no lead disturbance at all, placing the lead in the postural septal region. And so I think with patients with lead, I think there are options for them besides lead extraction, which I think the panelists will discuss that in a minute. But these are a couple of maneuvers that Paul has and team in Abbott have come up with, and we have published it recently in the Circ intervention, using in the IJ to pull the lead in the superior anterior maneuver on the left-hand side. Middle, you can see it rotate the lead laterally using a candy cane. And on the right-hand side, we had recently last week as well with a case maneuvering the RA lead away from the tricuspid and using TE to find that treatable gaps to place the clip and hopefully enrollment into the TRILUMINATE trial. And so the key points before I end this talk is I think for patients with lead, look for treatable gaps. You want to use steerable catheters to create these gaps correspondingly. So during the right heart catheter, that's what we do, TE imaging. Use the access point depending on the desired location. And as an interventional echocardiographer, use TE and also ICE imaging, as you hear numerously during this symposium. And with that, thank you very much.
Thanks, Nadira. So maybe I'll talk to Richard and Hursh and see what the audience thinks about this. I mean, gaps are certainly a challenge when we're trying to do transcatheter edge-to-edge repair. Maybe I'll start with the audience. How many of you have experience mobilizing leads when you're doing a tricuspid case?
That's a great case. Typically we've done it with the guide catheter itself and just kind of trying to get the clip in front of it and isolate it. But that's really nice. I think what's valuable to me, though, would be taking this approach during your diagnostic workup. Because it's not always as clear that those leads are movable. And you hate to kind of do all the work of getting up to the case only to get in there and find out you can't move that lead where you want it to be. So, we have certain cases similar to this where we work with our lead explanters to bring them in for their right heart cath. And during that, we do ICE imaging, use the ICE catheter to bat it around maybe to help confirm or just get better imaging to see if this is even possible.
Are you using the guide catheter from the clip device to push it around? Is that what you were saying?
Or just once the clip delivery is already in.
Oh, it's okay. Yeah. So sorry. So we, in TRILUMINATE, because there's a mandatory right heart cath. That's typically when we've done these. Is that we do it during the right heart cath. We just do it with anesthesia so that we can put the steerable in, and it's worked quite well. So where's my EP doctor? Debbie, are you here? Okay, I want to hear about lead extraction. No? Okay. How many people have partners who do lead extraction routinely? How many people have partners who love extracting leads in 85-year-olds where the leads are 5 to 10 years old?
How many people have ever seen a lead extraction actually work and reduce TR? Yeah, nobody. Okay.
No, that's not true. That's not true.
I know. So this is how we think of lead extraction in our place. Everybody take their left arm and hold it out like this. Hold it for an average of 6.5 years. Now drop your arm and play tennis. Yeah, you're not going to do that. That's what happens to these leads, because I've seen them in person, is they're completely fibrotic. And yeah, these guys work and laser the heck out of it, and it's 8 hours, and they get it out, and the thing still sticks out or it sticks down or something like that. Ugh.
Well, you know, my arm would be tired, Steve. It would be tired, but so is the leaflet. I mean, you know, for the trial, we had to remove some of these leads, and you know, sometimes the correction of TR was removing the lead. So I've lost patients in the trial because of that. But yeah, I agree with you. That leaflet doesn't look the same.
Did it depend on how long the leaflet had been in there? Because we have had just horrible results of lead extraction, and we've just decided to not really ever do it.
So we have a small series that came out as a research letter in JACC, and it was 33 patients, and there are 14 of them had actually improvement in TR after extraction, and they tended to be ones with minimal leaflet impingement with the lead down the middle. So exactly where it's not really hurting that much, but it's interfering with the path for the triclip or TR system. And so otherwise, if it's severely impinged, if it's entangled in the subvalvular apparatus, it's what Steve says. When you take it out, most of the valve comes with it. And so we actually, as a practice, size these patients for TTVR before we do the extraction, because we want to make sure there's an option in case they're not TR eligible after we do extraction. Richard, you have a comment?
Yeah. You know, initially we thought it was appealing to extract some of these leads and put like a leadless pacing system. Paul, you want to comment on how that worked out?
Not that great, yeah. And the reason being is that the leadless systems, they anchor by subvalvular cord entanglement, and so they take the cords and they wrap them and pin them down. And then we've had cases where you just simply can't pick up the leaflets afterwards because the cords become fibrotic and anchored. And so the leadless is actually the anti-panacea for this approach, unfortunately. Yeah. Other comments or questions about extraction? Perhaps I want to talk about lead entrapment, but maybe we can do that because we have a TTVR talk coming up. All right, our next presenter, Anita, Dr. Asgar. My most challenging transcatheter case for 2023. Who has the clicker? Marcus is always ready. Steve, do you want to come up to the panel here? You're always talking.
Great. So it's actually good that we talked about lead extraction. You're going to see some of that theme in this case. This is my most challenging tricuspid. I put in brackets mitral case. You'll see why. So this is my patient. She's a 33-year-old female with severe MR. So we'll talk a little bit about her anatomy. She's a congenital patient. So she had a detransposition of the great arteries. She had a Rashkin procedure at birth, and she had a Mustard procedure and a VSD closure. So she's had multiple surgeries already. She actually comes into hospital because she has an epicardial pacemaker with a ventricular lead from 2003 and 2 other leads from 2012. She also has stents in her superior and inferior baffles. So just to align everybody, she's got a systemic right ventricle, and she's got a subpulmonary left ventricle, and so her venous or her subpulmonary AV valve is actually a mitral valve. She comes in, however, for a lead extraction and implantation of a new pacemaker, and they were planning to put a covered stent in her superior baffle. And so her indication for a lead extraction was an RV lead fracture and under expansion of her stent in the superior baffle. So complex anatomy. So she comes in for her lead extraction. So you can see what they've done here, but she gets her lead extracted under laser. This takes several hours, and then I get a call to the hybrid OR that there's a problem post-lead extraction. Can I come and see what's happened? And they said, well, the valve is leaking a little bit more. So if you look at it, the valve is leaking a lot more, and what they've actually done is they've completely avulsed the papillary muscle. See, what you see flapping in the breeze is not just a flail of the leaflet, it's actually a chunk of the papillary muscle. And so we had a heart team discussion on the table with our congenital cardiac surgeon who felt, given she'd had previous forced sternotomies, this was going to be a hard case to do with her on the table. This was not ideal. And so they decided to go ahead and put the pacemaker in and see if we could figure this out. She's 33. Maybe we'd be able to manage her medically. But we weren't really able to manage her medically. She had right-sided heart failure. She was hypotensive. She was tachycardic. Her lactates went up. And so the medical treatment, she went to the ICU. She needed inotropes. And she really just wasn't doing well. And so the question is, could we do anything? So we looked at her imaging. So you can look at this imaging. She's got a ton of leads in there, minus the ones they've already taken out. She's got scoliosis. She's got baffles that are stented. And then she has this horrible anatomy. Whoops, so if I can go back. Can you play my last video, just that echo image? So if not, I mean, yeah, see if we can play that. Oh, okay, it doesn't want to play, but we did see it before. So basically what we have is, this is a subpulmonary AV valve, which is like a tricuspid valve, but it's anatomically a mitral valve, and they've ruptured the papillary muscle. And so the imaging for this is all strange, as you can imagine. We don't have standard views here at all. But she's 33 years old. She's not tolerating it. So we looked at all our options. We could operate on her. Probably not going to be able to put a ring on this one, though. Maybe we can repair it. But she had decreased systemic RV function, and so she was felt to be high risk for surgery. She had markers of increased mortality. Could we potentially tier this? It's off-label, obviously, and how are we going to do it? Which system are we going to use? So we do have commercial access for TriClip in Canada, so it was a potential option. Medical treatment we felt was not an option for her. She wasn't tolerating well. She's 33, and she's still in hospital. So we decided to try to attack this using the TriClip system, even though it's an anatomical mitral valve. But if you think of the anatomy, you can see she's got a stent in her SVC baffle. Very, very tight anatomy, very, very small ventricles. We were trying to figure out how we were going to manage this. The stents were actually super helpful because they gave us a landmark to try to steer with. The echo imaging was quite difficult. We actually only had one view where we could try to grasp. But we did take a TriClip system. We were able to straddle just using very minimal maneuvers, and we were able to steer down to the valve. And we were just trying to figure out if we could get a clip on here, what would we be able to do. So we managed to get an XTW on here, and then had a little bit of a residual leak, and so we added another clip. So I'll just show you the imaging. So we had this one view in the 0 degrees with X-plane to try to grab. We were able to manage it. And you can see we ended up putting 2 clips on here, an XTW, and then we added an NT at the end just to try to tack everything down. And so she was discharged from hospital actually 2 days later. Her echo at discharge was trace MR. She had a mean mitral gradient of 3, normal LV function. So she's 18 months out now. She's still NYHA class 1. She's got trace MR, and she had a stress test by the congenital people. She was negative, but she did 8 mets. So, you know, we were pretty happy with that result for her. So just what we learned from this case, I mean, these are rare cases. You don't see them very often, but it's nice to have something in your toolbox potentially to help these types of patients. Understanding the anatomy is the most difficult thing, and so we used all our modalities. We didn't have 3D ICE, but we used our CT scan to plan, TEE, and then the good quality imaging. Even if you have only one view, we were still able to manage it. And often the times, these are non-standard views. These aren't your traditional views to try to do a case like this. So thank you for your attention.
And Anita, could you stay there for just a second? So I think we have a lot of questions about this case, but what did you think about doing with the papillary muscle? I mean, did you trap it on the RA side or the RV side, or how did you?
So we trapped it on the ventricular side.
How did you do that? How did you time that? Because that's where, you know, we've had these presented here before, especially on the mitral side. And the results are better when you put the papillary muscle closer to its original location before
Right.
it tore. But how did you do that on the?
So two things.
Yeah.
First of all, we tried pacing because sometimes you can do rapid pacing and see if that would help us. It didn't, and so eventually we used adenosine. So I've seen people use that before for severe prolapse. I said, you know what? Whip out the adenosine. Let's try something. And so the adenosine actually helped us to catch that and keep it on the bottom.
Hursh, Richard?
That's an amazing case. As an echocardiographer, I would have been really scared. I have these PTSD from Carol Warren's kind of yelling at me during fellowship, about the anatomy. But that's kudos for getting that done. That's really amazing. Very challenging, and I don't know. The manipulations, catheter manipulations, figuring that all out on the fly. That's really amazing.
Yeah, that was a great case. I've done 2 of these papillary muscle ruptures on the mitral side, and I think to your point, both of those, the papillary muscle, you can sometimes grab leaflet, away from where the actual rupture is, but that papillary muscle flipping up and down creates a lot of problem, and so the kind of like the timing it just to grab the papillary muscle and bring it up into the left atrium has worked, at least for my N of 2. Work really well, but that's the contention more. That's the hard part of the case is more dealing with that papillary muscle, at least on the mitral side, more than just grabbing the leaflets.
So I'll be honest, when I was initially asked to do this, I said no. And then my congenital surgeon came to me and she said, this is a 33-year-old woman and her mortality is going to be excessive. Like, you have to try. And so our echo people also said no, and I thought, what do we have to lose? Let's just give it a go. If it doesn't work, we take everything out. And so we got very lucky. But I think it's important to use all your imaging. So what we found very helpful, myself and my echocardiographer took the CT scan and looked at it and tried to figure out what are the views that are going to potentially help us. How are we going to get around this anatomy, which was difficult, multiple surgeries. And I think using all the tools that you have and all the imaging you have is what's really going to help you. And patience. It was surprised. We planned only 1 case this day, and it actually only took us 2 hours. We were quite surprised. But, we had our time, and we ate breakfast, we had coffee, and then we went at it.
So, yeah. So in other words, you don't lose anything by trying. Is that what you're saying, Steve? Yeah.
So
Yes.
we didn't have any access to anything else at the time. So it would have been a high-risk surgery. We would have had to wake her up and explain to her what the situation was going to be. So, we got very lucky. She's very happy. But, yes, you do have to have your plan B. And our surgeon was there ready in case it didn't work out.
I have a question for you. So, do you think the tight corners were the reason to pick the TRICUPID system? But for people like us who don't have access to it yet in the U.S., do you think that case could have been done with our conventional TRICUPID system?
It's a good question, because I think what really helped us was the fact that the guy was a little bit shorter and we could steer a little bit better. I guess if we didn't have a choice, we would have tried it.
I'm not sure what knob you would have used, though. Because,
Yeah.
you had to use the F knob. This is clipping the AP commissure with the F knob. That's like what you,
Pretty
in terms
much,
of
yeah.
the steering. And so I don't know what knob you would have used for an off-label
Yeah.
device. If anybody has any idea, I'd love to hear, but I'm not sure. There's some Abbott folks over there. What would you guys have used?
Well, first, you probably would have gone from the left side, right, if you did the off-label.
Yeah, off-label.
femoral,
Yeah,
Yeah, that's a good point. Left femoral access.
left femoral.
No, we went very slowly, and honestly, the stent was very helpful because it showed us exactly where it was. So I could steer more on fluoro. My echo people couldn't see me at all, but the fluoro I was able to steer.
I'm really impressed you only needed 2 clips, because usually with that amount of height, for a prolapse, we would need 3 or 4. It's really impressive, which means you must have had an incredible grab with one or both.
So the interesting thing is we were debating whether we should take the longer, wider clip, right? And I didn't show you that view, but you couldn't even open it in the ventricle. It was so small. Because it's a subpulmonary left ventricle, and so you can't get the wingspan of the XDW open in there. It was way too small. So I could only really open it to about 60 to 80 degrees. And then we just scooped up from the bottom. And we were having all kinds of PVCs, right? Because we keep banging up against the wall. But, we managed to get it done. And luckily, we just added an NT afterwards.
Oh,
in that
so it was
little
an
space.
XT?
It's an XTW and an NT.
Wow, fantastic. Congratulations. Awesome. Thank you. Nicholas. Dr. Amoroso here for percutaneous valve replacement.
Hi, morning, everybody. So I'm Nick Amoroso from Medical University of South Carolina, and I was tasked with presenting a tricuspid replacement case, and mine is titled after the O.J. Simpson trial, "If the valve don't fit, you must not quit." These are my disclosures. So our case is that of a 69-year-old woman with torrential tricuspid regurgitation. She has a history of diabetes, hypertension, and AFib. More pertinently, she had end-stage renal disease from her comorbidities, which had resulted in a kidney transplant 6 months prior. Unfortunately, she had suffered subacute graft failure, and it was blamed on her right heart failure with kind of precipitant TR. She had class 4 symptoms, had returned to hemodialysis, and was really struggling with outpatient hemodialysis, actually requiring at least monthly hospitalizations for CRRT. So here we can see that she has pretty significant biatrial enlargement, an enlarged right heart, and a pretty dilated tricuspid annulus. Her coaptation gap is pretty wide and has torrential TR with classic triangular Doppler of her regurgitation. Looking at her IVC and hepatic veins, there's flow reversal, again, supporting her severity. And so, as is true for all of our TR workups, we'll do a right heart catheterization, which most commonly says you need more dialysis or you need more medical therapy and diuresis, but hers was surprisingly euvolemic, even with those imaging parameters. So where to go from here? So we know that many of the patients, as we've already described, frequently are not candidates for some of our other transcatheter therapies, either because of their comorbidities or perhaps because of their anatomic compatibility, I think most commonly now. And additionally, imaging challenges where we aren't able to see the components of the tricuspid valve we need to get device anchoring or appropriate placement. This was true for her. She was, because of her comorbidities, high surgical risk for repair. Her annulus was too large for available orthotopic replacement devices, and her coaptation gap was too large for edge-to-edge repair. But we still are looking for ways to decongest her IVC, reduce that venous hypertension to her transplanted kidney, alleviate her cardiorenal and heart failure syndromes and quality of life. So I'm excited to present to you guys today for the first time publicly our first in human use of the heterotopic valve implant with the Edwards Caval pre-stent. So on behalf of my partners here, Ryan Tedford, myself, Mark Katz, our friend from Henry Ford, Brian O'Neill, and Danny Steinberg, my partner, unfortunately missed the picture. But this is a mock-up of the device. It's an elongated self-expanding stent with open cells, except for the top portion, which has kind of a skirt, as we've come to know it with THV. It also has a docking station or a restricted portion at the top that is sized for fitting a 26 millimeter Sapien 3 valve. And this addresses many of the problems people have had with off-label CAVI in the past with either sizing for the THV or with stent migration that they were using to try and anchor them. When we came to implant, these are her hemodynamics to start. We see she's a little more volume up that day, hadn't had dialysis yet. Her IVC pressure and right atrial pressure are both ventricularized and essentially identical. We began the case with a venogram, and we figured out this angle from our CT analysis with a goal of isolating the most superior hepatic vein and the floor of the right atrium, essentially to try and have a perpendicular view of our landing zone. One of the many challenges for Caval valve implant is creating a seal, so you gotta have a zone where you can have tissue contact with your THV, and so this view helps us identify that. Next, the pre-stent was advanced up the IVC from the right femoral vein, and we used our markings on the screen to start the deployment. We have partial deployment here and could make small adjustments as we kind of let the pre-stored energy out of the device to try and really nail our very short landing zone for this patient, not an ideal landing zone in general. You also see how the stent on the screen left there, it kind of starts to billow out and in the hepatic IVC, and that's a pretty common shape to the IVC for a lot of these patients, where you have this hepatic vein confluence, and it's one of the challenges for getting a good fit for any of these stents, in effect. During the partial deployment, we still have the opportunity to recapture a large portion of it and then readjust our position as necessary. But once we reached that, then we went ahead and released the remainder of the stent here in the caudal portion. And then we prepared a 26 millimeter Sapien 3 valve to be advanced into the pre-stent. Of course, the valve is flipped upside down, so to speak, from an aortic position so that the inflow is headed the right direction. We centered the valve there on our markers for the pre-stent, and this way we can take advantage of both the THV skirt as well as the fabric that's incorporated into the pre-stent to get a good device-to-device seal without leak and try and maintain that competency. So our ventriculogram afterwards shows that there is still quite an enlarged right heart, torrential tricuspid regurgitation, as we have not done anything to the valve itself, but there is no longer contrast systolic flow in the IVC. So looking at our hemodynamics, on the left-hand side is what we started with, on the right-hand side is the result, and there is ventricularization of the right atrial pressure in blue line there, and in the red line we see the IVC pressure below the level of the valve has eliminated that systolic flow reversal. Her cardiac output did increase actually immediately after this intervention. I'll tell you, I think that in cable valve implants in general, that result is a little bit variable in the acute setting. So of course, this would not be possible without a tremendous team of people. Here, many of the members of our Edwards Advanced Technology team who have been working on this device for some time, and our team members at the Medical University of South Carolina. And so thanks to all of them. So a little case follow-up on post-op day 1. She underwent her planned hemodialysis session without any issues. She had CT and echo imaging for analysis and future comparison. Her implant result looked identical to how we had left it during her procedure, and she was discharged on post-op day 2. Most pertinently, this happened during fall, and she had been in the hospital so much, one of her biggest goals for quality of life was just being able to spend the holidays with her family. So as we've been discussing early this morning, you know, quality of life is important. It may not be our ultimate goal for a lot of these treatments, but until we can get to an ideal device, it's certainly important to our patients and to us. So being home for the holidays, the winter holidays, was a big win for her and for all of us. So key learnings from this case: heterotopic valve implant can be a viable alternative when an orthotopic implant is not suitable. It's not dependent on annular anatomy or leaflet anatomy, though you do have the caval anatomy that we have to contend with. It can be safely performed in those with right ventricular dysfunction because we maintain that pop-off phenomenon, so to speak, with the right atrium acting as our compliance chamber, but we are still able to decongest the venous hypertension for many of the end organs. Procedural imaging requirements are much less. While we used TE during this, I'll tell you that it was frankly adjunct, and many other caval implants are done with fluoroscopy only, and that's very feasible. Thank you.
Thanks, Nick. That's a great case. Tell me, do these patients need to be anticoagulated after the fact?
We had planned on anticoagulation, and I think just because it is a lower flow state, then we prefer that they be on an anticoagulant. How long they need to be on an anticoagulant, I think, is debatable, but our intention was to keep them on it. That's probably an issue, I think, for this population, because they are perhaps at a higher bleeding risk, and I know we've seen in other trials that people have a lot of problems with GI bleeds and other bleeding sources. So not ideal, but the concern, of course, would be that without anticoagulation, particularly with changing hemodynamics surrounding this valve implant, that you may be more prone to valve thrombosis. That's not a widely studied or founded statement, but that's the concern.
And so can you explain to us, those who have seen the trick valve, or those valves in both the SVC and the IVC, what are the differences, and how would you choose one versus the other? I mean, I understand you're protecting the liver with this system, but can you enlighten us a little bit on that?
Yeah, I think trick valves' early experience was they would use both. They would use either just the IVC implant or both the SVC and IVC implant. And then now their practice has become that they almost always put in both CAVA implants. The reason that they tell me they've moved to that is because people were experiencing a lot more headaches. Our limited experience, I'll tell you anecdotally, with this device, we didn't hear that from this small group of patients. And I think that from a symptom standpoint, that makes sense. You're almost creating an SVC syndrome, although not quite the same. So that has some attraction to it if you can make it fit. However, I think hemodynamically, I don't know that it's always necessary. I think depending on what you're really changing at that point is the afterload to the right heart. And by indirectly doing that, you're actually promoting forward flow, right? And I think over time that we see, particularly from the trick valve data, which is kind of our largest CAVI data set, that there are certain patients who do have right heart remodeling. So I think that even when we can't make the math work of pulling the annulus together, sometimes we can support the right heart in a way that decreases the volume overload, allows for the body to perhaps do some of that remodeling on its own and further support that.
So I was going to ask that question because I know Steve is going to stand up and say the math doesn't work here. Help us understand that physiology, because I hear about this physiology about cable implants and RV remodeling, but tell us, can you explain to us how does that work, or why should we expect that to be the case when we're not addressing the primary problem?
Yeah, not very well. I've spent a fair amount of time thinking about this and haven't come up with a clear-cut solution. I'd love to be able to have an equation, right, that we just said, well, if we reduce the regurgitant flow outside of the heart X amount, and then we're going to promote forward flow, you're ultimately going to reduce the preload to the heart, and that's going to promote healthy remodeling in a way that allows the right heart to heal. I don't know what that number is yet or what that equation should be, but it does seem to happen. It only happens in a proportion of patients, and I think that undoubtedly has to do with how early are we catching these patients, and additionally that they don't have other precipitating factors or aggravating factors like pulmonary arterial hypertension.
I mean, I think it's because there's an enormous capacitance on the right side, and you're capturing part of the capacitance, maybe not all of it, but part of it. Steve?
No, that's a fantastic case, Nick, and really interesting. I agree with you, Paul. The math doesn't particularly work on that. The right ventricle doesn't care where the volume is particularly going, whether it's going up or down, back. It's still spewing the. I would think that none of these patients would remodel the RV ever. And as a palliative procedure, obviously she did great, and so great. I had a question. Some of these patients we get into the same thing, and she even though you said she was euvolemic, her numbers were a little bit high. We've taken some of these patients and tried to dialyze them within an inch of their life, make them hypovolemic. They won't tolerate it very well, and then see if we somehow can cross that gap with like an XXXXTW, to try to just grab them. Did you think of that?
Yeah, no, it's a good point. We actually recently had a case of somebody from class 2 TR who was almost turned down because we thought anatomically it was going to be very challenging. Coaptation gaps were on the large side of what was allowable. We had not dialyzed, but diuresed him, signet about 40 pounds, and brought him to treatment and had a fantastic result, right? He had less than mild TR afterwards, and not because I think we were so skilled with our clips, it's because we had done the prehab to let that happen, right, to bring those leaflets together. For her specifically, they had struggled so much with hypotension during dialysis that even with continuous renal replacement therapy, we had never really been able to get her volume status better than the numbers I showed. So that was our biggest limitation for her options.
Yeah, we've seen a couple patients, if you switch from dialysis to CRRT, you can maybe get it better, but they're tough patients.
Yeah, I feel like these, like the trick valve and this, I feel like they're really just either palliative or that they will be a step to something else. I mean, if you get them early enough, or if the gaps are too big for leaflet modification or the valve's too big for TTVR, then maybe it will be something that you could do to then get them to the next step, because it will never preclude being able to do TIR or TTVR, like another tool in the toolbox. But I can't imagine that this technology will be the end as a treatment other than palliative.
Well, it is interesting because I think there are a lot of technologies that are dependent on a certain capacitance of the right side that we don't understand. And I think this is one of them. Atrial shunt technology is another one. We used to think it was just a math of QPQS, but it's much more than that because the right side has enormous capacitance. And I think Nick, if you're treating part of that capacitance, then I think it helps. But I think the question is, how do we figure out which of those patients have that capacitance, or what proportion do we need to treat of that capacitance to address it?
Agreed. I mean, I think every technology that we've talked about here today does not solve the problem, right? This is where we're at, is probably not the ultimate treatment, because we're not fixing the annulus, we're not remodeling the heart directly. And so what we're doing are things that support that. It's a step towards that solution. And I think the reality of it is that we need something to treat these patients and make their quality of life better, because we're not going to have that solution next year, or maybe not commercially 2 years after that. And so, 5 years from now, majority of the patients that we're seeing in clinic today are going to be dead and have severely suffered for it. So I think these are great treatment options for now. These are important for cases because no ideal therapy will ever fit every single patient. And so these have been really helpful tools, I think, for a lot of our patients.
Just one last comment. Wouldn't you have liked to seen this patient before she had tsunamic TR?
So I was skeptical, our renal transplant team is pretty adverse to taking patients to operation with TR. So I was surprised that this came up. But looking back, actually, her TR was at most T2 plus preoperatively. So suspicious. But they had at least done their due diligence.
Well, I think looking at the kidneys as end organ damage from TR is really important, and it's something that these patients benefit from for sure. So.
Kidney didn't come back. Unfortunately, she didn't have enough time to find out. That's the hidden slide. Is about 3 months later, she ended up getting hospitalized for urosepsis, and she kind of succumbed to the issues of sepsis a few months later. So,
yeah, thank you, Nick. Fantastic. So I have the pleasure of introducing my right-hand imager, Dr. Bay. Mini coaptation planes.
Thank you for having me, Paul. So Paul gave me this talk, many coaptation planes to treat, and yesterday he showed a few cases, and sometimes we see these and they can be challenging. So here's my disclosure. So we have an 80-year-old retired professor with severe TR. He's had 2 previous mitral clips. He has a CRT D device for systolic heart failure, atrial fibrillation, chronic kidney disease. And so on his baseline imaging, here you see he's not got the greatest images, and they're not always beautiful. Here, when we go to the short axis view, we can see that the lead is posterior, and the regurgitation is anterior to the lead. And this is our grasping view, where we see septal and anterior leaflets here. So when we go to transgastric, his heart's a little bit rotated, and we just see a lot of little fingers here. So this makes it a little challenging. Which leaflet is which? I think the ICD leads between the posterior and septal leaflet. Looks like the septal leaflet may have a couple of segments and maybe 2 anterior leaflet segments. If I do this, it looks a little bit more like Rudolph than a Roman arch, but little stick figure animal. So it's like, okay, how do we approach this? Well, I guess the point is it doesn't really matter what you label it as long as you're all on the same page here. And then when the patient came for the procedure, we see the TR is worse. It's anterior to that ICD lead. And so we have to decide how we're going to tackle this. And, you know, another picture of Rudolph there. So, you know, Becky's published this paper kind of showing the different variants, whether you call them segments or different leaflets. But, you know, this one maybe has 2 septal segments and 2 anterior segments, so it's doesn't fit any of these, maybe a variant of type 4 here. So intraprocedural imaging, supine is maybe a little bit more difficult than the baseline. Here we see the lead is still posterior and the regurgitation is anterior to the lead. As we bring the clip in, we can see some of the issues. Once the clip arms are open on the right, you can see that this is kind of a horizontal heart, and we just have a lot of shadowing of that lateral clip arm. So this is not going to be easy. So oftentimes when it's not exactly a clear cut, I'll just draw a line on the echo screen and say, do we want to go here to here, and we make sure we're on the same page without necessarily having exact labels. But it seems like just anterior to the lead, there's a lot of regurgitation there, maybe between one of the septal segments and posterior segment, if you want to call it that. And so we get a clip in, and we have the best view is the transgastric view, so we try to line it up in that orientation that we planned. That little dot on the right, it may be confusing. It may look like the clip is actually horizontal, but it's more vertical, and if we put an X-plane through it on the right, we can see both clip arms. So that dot to the right is the lead. And we can see that actually the posterior leaflet is already in, but that other leaflet on the bottom is a little bit hard to assess. And as you can see from our esophageal windows, we really didn't have good imaging from there. And so this is a case where actually ICE came to the rescue, and we actually had a good grasping view with ICE, and so we could grasp that area with ICE. We closed the arms a bit, and on the right we can see that we're anterior to that ICD lead, and that's the clip. So it's confusing because that ICD lead looks like the other clip arm. But we close it all the way, and looks like we have reasonable insertion as we let go of the clip. Now we have to look at the residual TR, and where do we go next? So it's like another triangle here, maybe between A1, A2, and A2 and posterior, if you want to call it that. And so what's our next target? So we figured that vertical orientation worked for the first one, and so let's try it for the second clip. And we get a clip in there. Looks like we get the posterior leaflet pretty well, as you can see on the X-plane on the right. but that A1 segment, just can't get it. It just keeps sliding off. It's a little bit shortened and curled. And so we struggle for a while, and we finally decide that that's not really going to work. So what's plan B? So we decided to go, well, let's try this way. And maybe this is between A2 and P. But it looks like there's a reasonable leaflet there to grasp. So we put a clip in, and it's more left-right in this position. And we use ice again to grasp. And there we got two funny positioned clips. But it seems like we got them in, and we have good leaflet insertion. That's the orientation of the two clips. And fortunately, with the color, we see that we have impacted the TR. And so this is from 4-chamber view. And this is 3D. And 3D wasn't very helpful in identifying the clips. So the point of this short case is sometimes the exact labeling of leaflet segments can be challenging. But irregardless, as long as everyone's on the same page, that's what's important. When standard strategies of imaging or grasping don't work, consider alternatives. So here we use ice for imaging, and we ended up clipping anterior-posterior, which is not often done. So even though the imaging isn't beautiful, you can achieve good results with some patience and communication. Thank you.
That was a great case, Richard. I think that this illustrates that, for TriClip at least, when all of you guys start doing it, that it's important to not distort the valve and really understand coaptation planes, because that's what you did, and you did it in an unusual way, but the best way, because if you don't get the coaptation planes right, you end up making it worse or distorting, and then you end up with SLDAs and different things like that. So, great case.
So I'd just like to make a comment. I think that was beautiful. And I think one of the hardest parts as the interventionalist is trying to understand the anatomy. And I think having us speak the same language, or I like that you draw the line, because if you tell me A2, it's S1, maybe just show me where you want me to go. It's a lot simpler. And so I think that communication is crucial, because the anatomy is not that simple. So that's fantastic.
Thanks.
Our echo guys are smarter than us, so you have to draw pictures.
See, the imaging's not beautiful. Remember, it's not the imager.
Thanks, Paul.
I want to hear Bruce, Elena. What do you guys think?
Well, what we were just commenting on was just obviously how different this is than mitral, where we come in with a plan and like 99% of the time we say these are the clips we're using, this is where we're placing them, and that's exactly what we do, and we get the exact result, the result that we expect. Whereas we're just coming on, these cases you have to be so prepared to make kind of game time decisions. Richard talked about the importance of everyone speaking the same language and the communication. And it's just, we talk about this in mitral, but I think even more in tricuspid, that you've got to be on the same page. You've got to be able to be willing to modify whatever your plan was going in. It could change. The anatomy sometimes, or not frequently, is different. As I think many of the presentations said, here was our imaging and the plan we had based on the echo we did a month prior, and then on the table it looked like this, and it was different. We had to change things up. So I think for us, the big thing is being able to modify on the fly and come up with a new strategy that's going to work.
Also, normal mitral anatomy is is always really the same if it's normal. But normal tricuspid anatomy can come in so many different flavors. And I think that that's really been the challenge, to really, really understand that. And obviously the community, you have to share the same brain on these cases. So that was excellent.
And I think it's, sorry, is there a comment? Yeah, go ahead.
Richard and Paul, just in that case, so the challenge that I sometimes run into in discussing this with the images or in the cases, when is enough, right? If you're struggling with the second grasp, and now you're now in the anterior posterior segment of the valve, already impacted TR with your first clip, which seemed to have reduced it, at least in my view, what I could tell by a couple of grades. The hemodynamic impact of TR and the clinical impact of how the patient does seems to be
Well, I mean, I think the therapy goals are really important, and I think what you're saying, it's true. You know, it's interesting when we look at the at least, we're not going to talk about surgical literature, Steve. I'm not going to go there, but at least in the transcatheter world, whether you go from 5 to 3 or 4 to 2 or 3 to 1, if you drop by 2 grades, even if you still have residual severe, your KCCQ improvement is plus 15 points. It doesn't matter. And so not that you'd want to obviously try to get down to mild or less, but it's amazing that there is a disconnect in terms of the grade reduction versus a quality of life improvement in terms of what the residual is left behind. It is true. But I think this case was one of those better lucky than good type situations. And you know, the other point about this case too, I think is important, is that we often talk about these number of segments of these leaflets, and Vinny's here in the back, and he always tells me there's only 3. You guys always make up these different numbers, right? But it's not just about whether it's segments or leaflets or treatable parts. It's about the coaptation planes, and we have to look at these coaptation planes in addition to the segments. And you have to, like what Steve was telling us with surgery earlier, we're trying to restore the coaptation, whatever planes got distorted, and put these clips in the right place. So. Yes, Lucy.
I have to give a lot of respect and props for the imaging. I think whenever you're going for A&P, there's a significant amount of shadowing, and as an imager, it's extremely stressful. All your esophageal views are off, and you have to find those grasping views. I think for me, my question is, when do you reach the ice? You know, at what point do you say, you know, your T is going to be limited and you reach for that ice imaging? Because without ice, I'm not sure you would be able to do the A&P.
I agree. I don't think we would have been able to. We've been using ICE to get familiar with it in all of our recent cases. And I think the threshold's pretty low. If we don't get a good grasping view from esophageal or transgastric, you know, now we have a pretty low threshold to say, well, let's put the ICE catheter in. But obviously there's expense, and that's still being figured out when is the best point to kind of shift to that.
Great case. Yeah, I saw the predominant regurgitation was clearly posterior next to the lead, but just in terms of like planning, it's a tricuspid valve, you're planning doing multiple clips. Was there any thought in starting off a little more anterior, just because, you know, once you put that posterior clip in, then you kind of are completely closing off the anterior septal area to go into that. I mean, in this case, it looks like you guys got great results flipping AP. But was there any thought process to start off more anterior?
Typically, we do like to try to start more anterior, work our way posterior, but that's basically based on the transgastric views. If it's a normal orientation, if you put a posterior clip, then that will shadow the anterior clip. But you can see on this heart, it was rotated, so it was less of an issue.
Yeah, that's true.
Hey, Paul, let me ask you a question. Would you agree or disagree that 5 years from now, 10 years from now, we're going to be using ICE for the right side completely?
I would say I would agree with that. Yeah, and it's the analogy I would extrapolate from is PFO and ASD closure. You know, we started out doing TE for those. Well, at least I did 20 years ago, and then we moved to ICE, even just 2D ICE, to do these conscious. And we've gotten incredibly comfortable with it. And I think tricuspid is probably going to move in that direction. It's still really early though. I mean, right now, we try to see how far we can get, and I know there are some of our colleagues have gotten all the way through cases with just ICE. I think that's still a little bit on the boundary. So we still have TE there as well, and having both there makes the whole procedure, first of all, not just efficient but safer. Molly, you're nodding your head there.
Yes, I think ICE is a game changer. I'm not sure. I mean, maybe you could do a whole case with ICE, but I still kind of like the idea of having both. But it makes it so much easier.
So I got to ask you, Molly, while you're there, with these multiple coaptation planes, would you have just put an evoke in?
Yes.
Okay. All right, fair enough. It's a quick answer.
Great, thank you very much, Richard. I'll invite our last speaker of this session, Dr. Molly Szerlip, to talk to us about coaptation restoration.
Anyway, okay. So, it's funny you asked about the TTVR. It's there's a reason why it's enrolled so much faster and is, may get approved even before the TIR. It's very efficient and not so hard to do. So, anyway, all right. So, the last case. This is well before there was things like ICE. So, and early on in TIR therapy. So, okay, this case presentation, this is a 70-year-old who had severe TR with symptoms, early satiety, fatigue, shortness of breath. She was a tiny woman. She weighed 46 kilograms. And significant for her history is she had horrible pectus excavatum, which made surgery, her STS was like 1%, but it made surgery not so friendly, and the surgeons didn't want to do this tricuspid because of that. You can't really appreciate her spine, but it was like pushed over to the left side, so that too, her IVC was pushed over and her heart was kind of rotated. So she did get accepted for CLASP EFS, so this is a Pascal case. This was during the case, so her TR may not look so bad now. She was under anesthesia, but trust me when I say that it was severe. This is a degenerative tricuspid case. She had a lot of prolapse in all of her leaflets, excessive leaflet motion, and she also had quite a bit of cords. Can you play that? So all these, no, go back. Yeah, thank you. So luckily though, we did have great imaging for this whole case. So it made things a little bit easier. And just so, because everybody's familiar with Triluminate and the TriClip. So we now have 2 Pascal clips, or devices, but back then we only had the big one, which is the ACE. Really the difference is how wide these are, and then the spacer in between is a little bit different. The good thing about this device, it's passive closure, so there's not a lot of damage to the leaflets if you make multiple grasps, which in this case was very much needed. So just to orient people on 3D, anteriors on top, septals to the left, and this too was one of those type 3B valves with 2 posterior leaflets. And like I said, we used the P10 or the big Pascal device because we didn't have ACE at the time. So our planning strategy was to have one that would be anterior septal, kind of in the 9-3 position, and the other one would be 10-4 in the posterior septal plane, again, to keep that coaptation line. So because of all the cords, the other good thing is you can actually go in with this device in an elongated position, and when you begin to close the device to get it in that 90-degree or 60-degree plane, you can just kind of scoop up the leaflets as they come up and not get tangled into anything. So here we grabbed and then we optimized in this. In all these, the third image you'll have to play. Since I have no mouse. Thank you, Paul. So we knew we had to put a second device in, so everything is going great, and it actually, we're like, this is not taking so long. So then we try to get oriented, and we try to move the device over in the 10-4 position, and this device it can move freely in 3 planes, which has its good and its bad. So if you're used to the TriClip, it's a little bit unnerving at first when you start using this device because it can spin all over the place. It's very easy to move. So we grabbed, actually, and I spared all of the images, and this was 300 images, because we probably spent the better part of 2 to 3 hours on this posterior, because we couldn't figure out why we kept rotating in this direction, because remember, we wanted to be in that 10-4 position. So we finally got rotated there into the right. We grasped, we optimized, and we were off again. So we're like, okay. So we keep trying. Here we are, and this is literally after maybe the 10th or 11th grab, where we finally get it more to what we like. We get a really great result with trivial TR. And you can see we are in the correct planes that we wanted. And so 4 years later, she's had no hospitalizations, no shortness of breath, and no early satiety, and she still has, trivial TR at the best. So the take-home points, it is, as everyone has said, I was talking to my surgeon, because we do these together, and we were going over this case yesterday, and he was like getting nauseous reliving this case, because we remember this case, and he's like, this is still the hardest thing that we do, I think, in structural heart. At least I do. It's getting easier now that we have 3D, but back then we didn't have 3D ICE. So it's especially reliant on imaging. You need patience, as Anita has said, to get the best result. The good thing about this device, elongating to stay away from the cords, is wonderful. The passive grabbing allows for multiple grasps without hurting the leaflets. 3D ICE will make this a much more pleasant procedure, and that's where I really would rather be right now.
Molly, can I ask you a question? So you said something about TTVR. When we do TTVR, it's just more emotionally satisfying. It's quicker, and you fire it, and you have no TR.
Oh yeah, it's
now,
like.
Okay, you put something the size of a Diet Coke can, and
I
you
know.
probably kill the RV, but emotionally you feel better. You have to go through that torture. What do you think are we going to get better at tearing patients? Because I think that's a better option, or something else other than TTVR. But it is emotionally more satisfying. Just go boom, no TR.
It is. A couple of things. I always say this, that our technology is advancing way faster than what we know about this disease process. And even with surgical results, so, we had that paper that our 1-year mortality was like only 3%, and we're great. But if you look at the 5-year mortality, it's the same as everybody else's 5-year mortality, which is horrible. So yes, those TTVRs are like huge Coke cans and seem to, it's more about paralyzing the annulus, I think, is what everybody's worried about. But even when we get these in, they're not living longer. We're still missing something. We fixed the TR, great, everybody's high-fiving, but we're not changing their mortality. And that's the key. I think that until we know that, I would much rather have these people feel better with TTVR right now than blood, sweat, and tears on TR sometimes. I mean, not all the time, you're right. There's some anatomies that are much better for TR, but for programs like us that have both technologies, I mean, we're totally biasing the results, right? Because we're looking at patients going, yeah, that's not going to be a good tier 1. We'll get a much better result with TTVR. And so I'm not really sure how that's going to play into this whole system.
So maybe I just had a quick question. So 4 years later, you've got more experience. What do you think was causing you to keep flipping around?
Good question. And I meant to say that. So really what it was, it's that sort of 3-dimensional planes that you can steer this device in. So every time we thought that we were going posterior and whatever, we were going anterior and lateral. So it just, I mean, the device was doing exactly what we were asking it to do. And so when we added more flex, we would like flex and move lateral flex, and it put it in the right place and stayed. So it was more of a learning thing.
Because sometimes what we find is it's usually some of the cords that we don't see that are doing that to us, and we don't realize it because we don't see it. And I think that might be where ice would be helpful, is if you can't see underneath sometimes the cords, or because that's been my experience. I'm trying to turn it, it's not responding.
Yeah, and true, except with this device, you can get it so out of the cords, because when you go in elongated, you look like you're still in the annulus, but then when you close the device, you're right there, you're out of the cords. So that's kind of what's unique about the device.
I think it's going to be really interesting when we go forth with these cases more and more, these degenerative cases, because these are so uncommon. I mean, I don't know what it is in class, but it was 6% of terluminate, so it's very uncommon. I mean, Steve, Vinny, I mean, degenerative cases of TR, I mean, you're seeing these or not seeing these? Vinny, you want to comment?
There's not many.
Most of the time,
It's functional.
concomitant, we assume it is functional.
Yeah.
I think in surgery, one thing really misses is here we spend so much time for weeks and months, CT scans, repeated echoes. I think characterization is much better. When patients are close into surgery, on either receive their or whatever, I think the characterization is missing. And I think now with more discussions beforehand, we are seeing more and more of this pathology. And as you said, it's not surprising that we're classifying them both into functional, sorry, primary or
I certainly, even though the leaflets are longer, I think they're harder to treat because of the need to bring that height down. I
Yeah.
mean, you did a really good job of bringing the height down with your two devices. I think if you had used smaller ones or the ACEs, you probably would have needed a third device in there. So good. Any other questions, comments? All right, well, it's a great start to TR squared. We'll take a break here and be back here at 10:30. So thanks, everyone.